Yeah, researchers call it the cascade effect. If you start with one intervention, you get more and more and more. It just kind of snowballs. Let's take a look at the Mount Eaton, am I getting this right?
Yes.
Mount Eaton Medical Center. Your head nurse, Mary Patterson, is going to talk a little bit about your obstetric practice there.
Yes.
I'm Mary Patterson, the head nurse here at the Mount Eaton Care Center. I've been here a little over 12 years, and I really do love it here. I worked in OB at Millersburg for a while, and the difference is amazing. It's so technical there, a lot of machines, and this is more natural environment, more like home setting for the patients, and they can have the medical care but still have the comfort of home. If they need any extra help, we're here to help them. Most of the ones that have had babies before, a lot of them are really quick. I mean, they come in, we had one just last night that came in complete and delivered within like 3 minutes after she got here. That happens once in a while, I mean, pretty frequently actually. But I'd say the longest are the first-time moms. Sometimes it takes them maybe a whole day or a day and a half of labor to have a baby. But if they're steadily making progress, we don't worry about it. It's hard for us to see such a high cesarean rate here because all of our patients are screened really well before they come here, and they need to be low-risk patients. So it's rare that we send someone out for a C-section. Sometimes we'll send somebody to the hospital because they're not progressing in labor, but they can do some things at the hospital that we can't do to get them to deliver vaginally. So we don't really see the rate of the high C-sections like they do probably in a big city. But we don't have liability like the doctors do. Each doctor carries their own if they have it. Now, we have some doctors here without liability insurance, but the Amish and Mennonite people don't normally sue, so they're not as concerned about it here.
Now, Mount Eaton is the oldest freestanding birthing clinic in Ohio, is
Correct.
that right? About how many years?
About 28 years.
About 28 years, and you've worked there the entire 9 years that you've been practicing. How many babies did you deliver there last year?
I do about 60% of my deliveries there, and I do about 275 deliveries a year.
But the clinic as a whole, so they delivered even more than 275 babies.
They deliver
at the clinic.
around 500 a year.
Now that's more than our local hospital does here in
Yes.
Athens, Ohio.
And it's more than our local hospital does where we are too.
That's an extraordinary, and to say that the cesarean section rate there is so low, that is quite a statement to make. Now, when Mary Patterson, she was talking about low-risk births, that at a freestanding birthing center, you want to make sure you have low-risk moms there. What does that mean exactly?
Low risk means that they're more than 37 weeks gestation because you want to have a baby that's ready, that's not going to have breathing difficulties. They can't have medical risk factors that would make themselves or the baby at higher risk during the delivery.
So no high blood pressure,
right?
No gestational diabetes.
Actually, gestational diabetes that's well controlled on diet is not considered to be a problem. If they need medication to control it, then that's a higher risk. Thyroid disease that's not adequately treated or under control, kidney problems, heart problems, those kinds of things would make it more complicated. And so they are screened out and don't go there.
Now these days it's very unusual for a mother to come into a hospital in labor. That's the exception rather than the rule these days.
Right.
Tell me what happens at your center. Is that the exception, or is the rule that the mother comes in labor and the exception is that you might augment or induce? How does it work? What's different about your center?
Because it's a freestanding birthing center, we only do normal. Inductions aren't normal, so we don't do inductions there. And if a patient needs an induction, they need to be sent to the hospital, not to the birthing center to begin with.
Well, now let me interrupt, because I'm thinking now like an obstetrician might, and they would say, well, what about if you have to augment labor? What if she's not moving at a fast enough clip, and what if she's not dilating at the way we think she should be dilating? Do you augment labor?
We have not until recently. We just got an exemption from the Ohio Department of Health to augment late in labor. Once in a while, these moms that have had lots of babies get stuck, and they just need a little bit of Pitocin to get them delivered. But up until recently, that person would have to be transferred to the hospital. But we also have some herbs that we use that will stimulate the labor just enough to get us past that point. We use positioning. We have a birthing ball, or we get the mom in a squat position. Positioning can do a lot to make the labor progress. And also, what's happened in the hospitals is we define normal so narrowly. A lot of ladies don't fit the definition. But in fact, if you look at the history of the practice of obstetrics, for first-time mom, the labor can be long. 16 hours is average. That means some go shorter, but some go longer. So 24, 36-hour labor, as long as there's progress and no signs of trouble for mom or baby, should be acceptable.
And this is normal. This
is
is
normal.
when you talk about normal birth.
Exactly.
This is normal.
Right.
What do you do for pain management?
We do have some injectable pain medications that we use, but we don't use any IV medication. If we think there's a need for an epidural or something more intensive, they have to go to the hospital for that. Once in a while, a first-time mom will just get exhausted, and the labor's not progressing because she's too tired. We'll send her to the hospital. We'll give her an epidural. We'll let her sleep, and then she wakes up ready to push out her baby. And so that's one of the things that Mary was talking about, that sometimes the moms are transferred to the hospital, but that doesn't automatically mean they're going to end up with a C-section.
But for the most part, I imagine, who's with the mom when she's in labor? I know around here you might have a doula, you would have your partner, you might have some friends. Is it customary at your birthing center to have a group in there supporting the mom while she's in labor?
These people are very private. They don't want any groups around. Traditionally, the husband will be there with the mom and the nurse that's on duty at the birthing center. And a lot of the providers will come earlier than you might see them come to the hospital. I try to be there with my patients the whole while they're in labor, unless I have office hours that prevent me from being there the whole time. But I don't like to run in at the last minute and catch a baby. I like to be there and see that the patient is progressing normally and help her out.
Tell me a little bit about the hospital that you work with. If on the rare occasion if moms are transferred, the hospital, obviously they work with you well, they know your practice. How does that work? Because I imagine this is a hospital that also sees all the standard things that you would see at a hospital. So how
Right.
do they treat your patients differently? Is this something that they learn from as well?
Actually, it is. They've changed the way they handle a lot of their patients as a result of our practice. And we have what we call a alternative birth option now, which is a birth center-like birth in the hospital, which can be done with water. We've got tubs for labor assistance, for pain management, and delivery if you wish. And that's been a real exciting thing to see happen there. We just did some preliminary studies on our deliveries since we have the tubs available. There were 49 ladies who used the tubs. Now at our hospital, the C-section rate runs about 20%. So out of those 49 ladies, you would have anticipated that 10 of them would have needed C-sections. Out of the 49, none of them did. So we're seeing more normal at the hospital. They see the need to accommodate the Amish patients and their large families and not to be quick to do C-sections. And so I think it has affected the care there as well.
You know, I recently interviewed an obstetrician at the University of Chicago Lying-in Hospital. She was trained in the early 90s when they had a midwifery program there. She said when she was a resident, it made all the difference for her that she would go and look at how the midwives attended births and how different it was from her own training, and it really changed her sensibility. Since they closed the midwife program, she said, residents treat birth entirely differently, that they don't see that different attitude of what normal is. And she said it makes her so sad for the residents because for her, it changed everything about the way she viewed birth. And you're describing something similar, what you've been able to do for a local hospital and teach them. Does that local hospital do vaginal births after cesareans, something known as what's known as VBAC?
Yes. They do, and they're one of the few small community hospitals that still provide that service. It became an issue when many of the hospitals were stopping doing VBACs, and we discussed should we or should we not. And we looked at our patient base and these Amish ladies that you would actually be increasing their risks by repetitive C-sections than to allow them a vaginal delivery. So The standard of care now is that you need to have a surgeon available and anesthesia available. Small hospitals can't afford 24-hour in-house anesthesia, and ours can't either. But the compromise that we came to was that when a VBAC comes in labor, the OBGYN plants themselves at the hospital, and anesthesia comes in, and they stay as well. So while we don't have 24-hour in-house anesthesia, when a VBAC is there, we have all the personnel available, so if there is an emergency, we can move quickly.